Good evening, dear ladies and gentlemen, dear doctors. Welcome to yet another CAP-free CME webinar. Tonight, we have to thank botiss for the support of this webinar, and we welcome Dr. Giorgio Tabanella from Italy. Hello, Dr. Giorgio, can you hear us?
Hello. Good evening to everyone. Thank you for hosting me.
Hello, hi. And we have Dr. Nadim, our favorite moderator, joining us from Lebanon. Dr. Nadim, can you hear us well?
Excellent. It's always a pleasure to be with you.
Thank you. It's a pleasure also to have you with us. Dear doctors, a reminder that today's session is recorded. It's going to be 90 minutes today, including the Q&A. So you're in for a very interesting topic. And we're going to talk about predictable and safer GBR using biodegradable metal membrane with Dr. Giorgio. The session is accredited for 1.5 CE credit through CAP as an ADA CERP recognized provider, and you will be receiving the certificates after 24 hours from this evening's webinar to your registered emails. If you have not received it by tomorrow evening, please contact us at events@capmia, and our team will do their best to help you as quickly as possible. A final reminder that we have our big CAP Dental Confex coming on the 14th and 15th of November, where we have a program for all specialties, including the full dental team. And of course, we have once again the MENA Aesthetic Dentistry Awards, where you can submit cases in 27 different categories, again, in all dental specialties. The deadline for submitting is 15th of September, so please make sure if you have interesting cases and you want to try and win, please submit those to us accordingly. Dr. Nadim, I'll leave it to you now to set the tone for the evening.
Thank you, Mr. Diano, for this very nice introduction. And again, I'm going to stress on the MENA Award, and the deadline is 1 week from now. Please be many to submit your cases. It's a very interesting, challenging event. And without no further delay, Dr. Giorgio Tabanella is from Italy, and he is going to talk about the resorbable metal membrane from botiss, our supporter for tonight's webinar. Dr. Tabanella is a diplomat of the American Board of Periodontology. He is an active member of the Italian Academy of Aesthetic Dentistry, author of the book, Retreatment of Failures in Dental Medicine. And this is a challenging topic, usually. He graduated from University of Southern California in Los Angeles, USA, where he obtained the certificates in periodontics as well as the Masters of Science in Craniofacial Biology. He was awarded Outstanding Periodontal Researcher in Surgery and Implantology by the California Society of Periodontists for his study on bone remodeling. Furthermore, he is the scientific coordinator of the International Implant Conference, director of OREC, Oral Reconstruction and Education Center, and reviewer and author of original articles published in peer-reviewed journals. Dr. Tabanella lectures in many countries around the world, and he is well as the U.S. and he's well known in the U.S. on implants and periodontal surgery, aesthetic management, and dental implant periodontology. And his CV goes long and long. He has many researches and focuses on tissue regeneration. And this is the topic that we will be discussing today. And he maintains a private practice in Rome, in Italy. Dr. Tabanella, it's very interesting now, shifting from biodegradable material into metal degradable material. What is the advantage and why are we going into this? Is there any backfire on the metal when it biodegrades in the body? How is it eliminated from the body? These are many questions I started with before you entered the presentation, just to keep our participants at edge.
Well, thank you very much for these interesting questions. Actually, the magnesium membrane is something between the two different worlds of resorbable biomaterials and non-resorbable titanium reinforced membrane. So basically, I would say that we can put together advantages of both worlds in just one single device. But it's not only like a device, we are just adding nutrients to the cells because the magnesium tends to degrade and release magnesium salts that will be utilized by osteoblasts to produce new bone. So it's a super interesting world in the field of tissue regeneration, actually.
Thank you. So let's see how it goes, and you may share your screen for our participants. Thank you.
So thank you very much. I guess everything is fine. I call it this presentation intelligent grafting procedures because we are really looking into something which is new, but not only something new which is just brought into the market. We need a real innovation. That's why it's intelligent. So I'm gonna start making a journey together with you, and we're gonna start looking at different perspectives on how the magnesium technology can be utilized in dentistry. The entrance level with the socket shield technique, GBR, how we can manage complications, then we can, if we have time, jump into soft tissue manipulations, and finally the retrievement of failures. So let's start just looking at this example. I'm seeing more and more often this type of clinical disaster, I would say. Here we have extensive bone remodeling around the neck of the implant. We have poor quality and quantity of the pre-implant mucosa. And of course, this is iatrogenic dentistry. So these implants are alien dental implants, meaning that are still functioning, but of course, this is not a successful result. And this type of situation are increasing worldwide. It could be in Asia, it could be in the North America, but this type of situation are dramatically increasing. So we should ask ourselves if maybe we didn't perform a correct hard and soft tissue boosting prior to implant placement. So we live in the era of simplification, but we need to simplify the procedures in guided bone regeneration. So we had to do GBR whenever it's needed to be done. If we look at some data, we have seen that starting from 2007, we see more and more often complication, which means an increased prevalence of implantitis. And why this type of clinical results is occurring in daily practice? Well, it could be related to the fact that we are not maybe controlling the periodontal status of the patient. Maybe in order to speed up the healing process, we don't do guided bone regeneration. So there are many, many different factors. But this is a classic example of failures in implant dentistry, and is related to, of course, poor quality of bone and soft tissue reconstruction. And several times I had to remove these implants, especially when I'm dealing with an implant with a poor quality of implant surface. So the first concept that we need to keep in mind is why we had to face this type of failures. Well, maybe we need to overbuild the sites. And if we go back to the literature, this is very well known since this beautiful review published by Spray in 2000. So it's more than 25 years that we know that if we don't have at least 1.4 millimeter of vital bone around the neck of our implant, that bone will resorb. And that's why we are facing and seeing more and more cases of failures. Of course, I have to retreat all these failures when they come to my clinic. But one important concept is that we need to have at least 1.4, 1.5 millimeter of vital bone, okay? So this type of results is due to the fact that implant being placed in less than 1.4 millimeter of vital bone, and that bone will resorb. And once the bone is going through resorption, we'll have the implant surface exposed to oral cavity, will get contaminated with bacteria, and then we'll have a secondary periimplantitis. But we start having excessive periimplant bone remodeling due to the fact that we're missing the buccal bone botany. And then, of course, there's another concept related to the soft tissue manipulation, but we don't have that much time to go over that today. Another important point is that every time that our patients are aging, okay, the implant tends to go in infraocclusion, meaning that we have the maxilla that is going down, and there is a natural bone remodeling going from buccal to lingual. And this is something we need to have very well in mind. This is more pronounced in female compared to male, but that's the results. We have an open contact, and of course, we have excessive bone remodeling on the buccal aspect. This is due to the aging process. So this is one more reason for which we should perform tissue regeneration all the time. Now, when we talk about guided bone regeneration, we just focus on guided bone regeneration. This is a quite tricky type of technique because, of course, this is related also to a certain percentage of complications. No matter if we use titanium reinforced membrane or if we use a titanium mesh, still we can deal with complications. And once we get this type of complication, we are ruining all results. And if it's happening in the first couple of months, we have to start all over again, do the re-entry, numb the patient, remove the biomaterials, and again, try to manage all the psychological aspect of treating these very complex patients. If we start looking at the literature, and even if this guided bone regeneration technique is very operator sensitive, but still we have developed a lot of tips and tricks on how we can reduce complications and allow everybody to do guided bone regeneration today, including general dentists, general practitioners. Still, if you look at the literature, and this article has been published by super talented and expert colleagues, we still see that complication goes from 0 to 45%, which is not acceptable that 1 out of 2 surgery can have some kind of complication. Then, of course, if this type of complication occurs, which means open wound healing, okay, in non-resorbable membrane, of course, if this titanium reinforced membrane or this titanium mesh get exposed after guided bone regeneration, the risk of failure is extremely high. So we don't know how we can manage this type of situation. That's why we're looking into new technologies to see how we can reduce the healing of these complex clinical cases. Now, let's start looking at this clinical example and try to see how we have been doing guided bone regeneration so far. So this is a patient with the generalized advanced chronic periodontitis. There is a failing, of course, teeth due to advanced periodontal disease. I have to extract the teeth, of course. I have to remove all the granulation tissues, and I have to remove also the old fixed restorations. And after 2 months of healing, I have to deal with this kind of ridge deformities. Of course, here I'm missing pink aesthetics, which is related to soft tissue, and I'm missing, of course, the bone, which is lacking in this type of situation. So this patient was coming from abroad. I'm used to see a lot of patients coming from abroad all the time. So I need to manage also the provisional phase in such a way the patient can heal very well, still reducing the risk of complications. So the patient was flying in and out on a regular basis. After 3 months, now the soft tissue is absolutely stable. We see, of course, that there is a lack of depth of the vestibule. There is a high frenulum attachment. We see mucogingival deformities. And of course, I'm missing some kind of pink color due to the soft tissue deformities and due to the lack of bone in that region. So now, how I was doing things? I was executing my tridimensional bone reconstruction. Now I'm just looking more into the details of the soft tissue. I do generally like to manipulate bone first and then jump into soft tissue manipulation after a few months. We open up the sides, it's a full thickness flap. We see that we have a buccal lingual collapse of the ridge, but we have not only the horizontal collapse, but also we're missing some millimeters of bone in the vertical aspect of this edentulous region. So Until a few years ago, I was using my cerabone. Today, I will use cerabone plus 100% of the time, mix it with autologous bone chips harvested from neighboring areas or from the ascending ramus. The way I harvest autologous bone chips is by using manual instruments. That could be bone scraper or special instruments that are designed in the past, or even back action and other instruments. And I want to have some kind of consistency. I mix my cerabone with autologous bone chips, and then I fix the JSON membrane, which is my favorite resorbable collagen membrane. Then I had to pack properly both autologous bone chips and cerabone or cerabone plus. We do know from the literature that cerabone plus tends to have a better outcome compared to other type of bovine bone. This is due to the fact of the production process that can lead to a higher density of osteoblast cells and count. Still, these materials has a very high porosity, and this can be very, very important because the rough surface and the high porosity allow to have a better hydrophilicity and also better blood clot stabilization compared to other type of bovine bone. So not all the materials are the same. There is a quite big difference. So going back to the clinical case, I start stretching the JSON membrane. This is something I can do with the JSON membrane because that's the pericardium membrane, which is very, very elastic, very, very resistant. I need to stretch it. I need to fixate with osteosynthesis screws or with titanium pins. Okay, so the result has to be that if I take my fingers with my sterile gloves and I keep applying pressure on the GBR side, it sounds like a block graft. So I don't need to have that space underneath the membrane. And I stretch the membrane. This is something that can be done only with few membrane available in the market. And again, the JSON is my favorite. I do my interlocking sutures. I let it heal. And then again, please remember that this patient was coming from abroad, okay, was flying in and out all the time. So by using resorbable collagen membrane, I'm reducing the risk of wound opening. And in case of wound opening, in case of complication, that size is going to heal by itself. That's why it's so important and crucial to use more and more often resorbable membrane. So the patient came back after 1 week, and what do I see here? I see a slight delay in the healing. The patient is a little bit sensitive on the palatal aspect, and he got a viral infection. There's an herpes virus infection the week after the surgery. And of course, this can lead to a delay in the healing. I let it heal. I'm not concerned the patient's flying in and out, but I'm not concerned it's going to heal by itself. So we are completing the safe side now because we're using the JSON membrane. I let it heal. 2 weeks after, I remove the stitches. And then I check again the tissue, as you see before and after. 1 month after, that's the healing. This completely uneventful healing. Actually, the soft tissue looks even much better with the frenum, which is a little bit higher. This is due to the fact that I have to release the buccal flap in order to have a proper colony position flap. And of course, the buccal bone balcony is going to be of help to get also a very important type of appearance of the soft tissue. That's why I like to work at the level of soft tissue after a few months. That's the results 2 months after, and 5 months after, I'm ready to do the re-entry. So I took my CBCT. What do I see here? I see that my GBR sites look like a block graft, but I did Guided Bone Regeneration, which is much more simpler compared to a traditional block graft, because I can trimensionally reconstruct the site. I can do horizontal and vertical at the same time, which is something very, very common in cases of bone atrophy. So in that sense, GBR works much better compared to block graft if I want to get some kind of vertical. And that's the results before and after. The beauty of the cerabone is that it looks like a block graft and is absolutely very, very stable. Of course, the handling properties are even much better if we are using the cerabone plus. So hyaluronic acid can be of great help to get a so-called sticky bone. I open up the flap. I did the full thickness flap. I see that I got exactly the best I could get because the bone is flashing with the head of the screws. So there is no bone remodeling around the head of the screw. That's a good sign. I still see the junction between the augmented bone and the native bone, but we're able to get vertical and horizontal augmentation, and we're able to get also the buccal bone balcony. Here we see the osteotomy site is half of it within native bone and half of it within augmented bone. So there is no alternative to bone reconstruction. So we cannot just keep extracting teeth, try to find some bone. We need to do whatever is needed to be done. And guided bone regeneration can be a great help. Of course, we reduce a lot with this kind of protocols the risk of wound opening and complication. That's why now this type of approach is very, very easy for everybody. Still, after 5 months, we see the junction between augmented bone and native bone, but there is a good blending of the sites, as you see here in this area. And of course, we got also some vertical ridge augmentation, as you can see here in this type of results. Here, we did like also bone biopsy to see the healing, but we see the results before and after from the buccal view and from the occlusal view. So now we are quite satisfied that we can place the implant in the proper prosthetic-driven direction. We see that all the implant completely surrounded by good buccal bone balcony, which is definitely thicker than 1.4 millimeter. Several times I like to use the caliper to measure the thickness of that bone around the neck of the implant to see if I need to do some kind of other adjustment. But we see here that we got more than 5 millimeters of horizontal regenerated bone around the neck of the implant. This is still the cerabone particles with a good blending. Now we did sutures 2 months after. Now I'm ready to do some kind of soft tissue manipulation. I want to increase the quality and quantity of the perimplant mucosa for many, many reasons. Here we see that the soft tissue looks even better compared to the previous surgery, but I still didn't execute any kind of soft tissue manipulation. That's the results of my bone architecture reconstruction that I did. So I did the uncovery, and now how do I deal with the soft tissue? Well, I like to use the mucoderm and suture the mucoderm on the inner side of the buccal flap. Of course, I'm executing a full thickness flap because that's part of the research program that we did it, and I had to do, of course, a picture after the reopening. So now I'm working at the full thickness flap, but it is very difficult to stabilize any kind of biomaterials or connective tissue graft. So I took my mucoderm. I like to use more and more often biomaterials rather than harvesting a lot of autologous tissue from the patient oral cavity. And again, a suture with PGA suture the mucoderm with the inner side of the buccal flap. Here it is. Still, we see the mucoderm on the inner side, just in conjunction with the buccal flap. Now, the mucoderm, it works very, very well. And what I like the most is to see new blood vessels within the mucoderm. And we see also island or connective tissue around the mucoderm. So this is absolutely an excellent type of results. Then I start sculpturing the soft tissue. So my goal at the beginning is to increase the thickness and also the height of the soft tissue with some kind of technique that we did it. Here I use the mucoderm again. And now we see that I'm gaining keratinized tissue around the neck of the implant. I don't have to do any kind of repositioning of the frenum. I don't have to do any kind of exposed wound technique because I'm restoring the depth of the vesicle through this type of manipulation. But that's how we move. That's the starting point. And that's how we finalize the case, bringing down the bone first and then the soft tissue. So we have two different types of hard and soft tissue manipulation with the same patient with a couple of surgical interventions. That's the results before and after. Patient again was coming from abroad, very, very easy, no risk of complication, no problems whatsoever. The patient got also an herpes virus infection, which brought to a delay in the healing, but still we are completely safe in what we are doing. That's the thickness of the pre-implant mucosa. As you see, a good band of keratinized mucosa, which is very, very important. And that's the starting point, as you see here, with the high frenum attachment, loss of the depth of the vesicle, and that's how we restore the implant with a very simple surgical steps. That's the results before and after. Nothing nothing painful. The patient actually didn't have to take into account of painkillers, and it was very, very easy to properly manipulate hard and soft tissue with the same patient. So again, that's how we started, and that's how we brought down the tissue. We see here the power of bone and soft tissue manipulation with this type of biomaterials, of course. That's the final fixed prosthetics supported by implants, and we see the bone is above the implant platform, very, very stable, no bone remodeling. That's the results before and after from a lateral view. Now, when it comes to soft tissue, we know that we need to provide at least 2 millimeters of thickness of soft tissue in order to prevent peri-implant bone remodeling and bleeding and inflammatory responses. But also we need to get at least 2 millimeters of keratinized mucosa in order to prevent further breakdown, but that's a different topic. So we got everything. First, we work at the level of the bone, and then we switch to the level of the soft tissue. And again, here we used cerabone and jason, and of course the mucosa. That's the 3 types of materials that we use. But now, do we have something new? Well, the answer is yes. Of course, we have something new, but we also have a real innovation when it comes to the field of guided bone regeneration, the magnesium. Okay, botiss was able, after many years of advanced research, to produce magnesium membrane. And of course, when this magnesium membrane tends to dissolve and tends to go through corrosion, because it's absolutely a metal membrane, but is absolutely resorbable, tends to release in contact with fluids magnesium ions. And these magnesium ions are utilized by bone cells during the different phases of osteogenic differentiation, osteoblastic activity and proliferation, bone formation, and mineralization. So again, this is not only a device, we are adding nutrients to bone cells. And I don't want to bother you too much on Monday evening, but we need to keep in mind a few important advantages of the magnesium membrane. It tends to stimulate osteoblastic growth, proliferation, and differentiation. In vitro study is able to stimulate stem cells changes towards the osteoblastic line, and that's very, very important. In contact with tissue is able to stimulate cell differentiation and in vitro, and of course bone formation in vivo. That's very, very important. So this is something new. Of course, this is new, but this is real innovation. This is going to change, and I can tell you this for sure after many years of research that I've been doing in this field. Is going to change the way we do guided bone regeneration. Another important advantage of the magnesium is that it's able to stimulate the neovascularization, which is so crucial when we are looking at tissue regeneration. We need to get new blood vessels formations. So no matter what we have is a magnesium membrane, or if it is magnesium screws, there are still resorbable that tends to degrade into magnesium ions and hydrogen gas. So there is a quite increased demand of using something which is completely synthetic. Patients love it, something which is completely synthetic and resorbable. We are going to spend less time on the chair. It is biodegradable. We need to avoid a second surgical intervention to remove the membrane, and it's absolutely safe. But it's also mechanically strong. It's a metal and still synthetic and completely resorbable. So this looks like really the holy grail. So bodies produce a membrane, which is made of 99.95% of pure magnesium, and then a different series of screws. The one that you see on the top is the extra small screws. The one that you see on the lower aspect of the right picture on your screen is used to block fixation. So the one which is on the top is the extra small, used in conjunction with the magnesium membrane. These type of screws are still completely resorbable, but they go through a process of passivation effect, which allow the screw to last much longer. So if we're waiting for about 16 weeks before the membrane is completely resorbed in terms of histological findings, but I would say that after 2 months, we don't see the remnants of the membrane. When it comes to the screws, they tend to last 4 months. So they tend to keep their biomechanical properties for 4 months, but still we're going to see the remnants for about a year. Of course, they are both completely resorbable. There is no inflammatory responses. The results are quite interesting. But what's the science behind? Well, if you want to understand a little bit better about the science behind this new technology, these are the most important papers that have been published on the Bioactive Materials Journal, which has an impact factor almost 15. So these are amazing. The one, it tends to explain a little bit better how we use this magnesium membrane. The other one on the right-hand side tends to explain a little bit better how we use these screws. So when it comes to the membrane, first of all, again, it's metal. Okay, so the tensile strength is definitely higher compared to other collagen membrane which are available in the market. So there is no comparison. And of course, there is a big advantage. Every time that we're dealing with something which is a little bit stiff, okay, it means that it tends to preserve much better the space underneath the membrane. And that's a prerequisite for perfect results in guided bone regeneration. So this tends to prevent the collapse of the membrane. And we don't need to stretch it because basically it tends to maintain the shape that we gave to the membrane itself. At the same time, the still maintains excellent handling properties. So it is very, very easy to manipulate, but still remember that you need to go through a learning curve. So even if you're super expert in guided bone regeneration, it takes some time to understand the tips and tricks. And really, my suggestion would be to take some specific courses on the manipulation of the membrane. Okay, even if you're super expert, because the handling is completely different compared to what we know, such as titanium mesh, collagen membrane, or titanium reinforced membrane. So how does it work? We have at the beginning a metallic phase, but already after a few days, the membrane start going through a corrosion, and there's a release of magnesium salts. These magnesium salts will still act as a tenting effect, and the magnesium salts will be utilized by cells to produce bone. Actually, there are nutrients for the osteoblastic lines. If we start looking at this macro CT done on buccal dogs, what do we see? We see on the left-hand side, already after 1 week, some holes within the membrane. And you might think, okay, so it's going through excessive resorption, but actually this is not a problem. This is a major advantage, because we still see the connection between the periosteum full of blood vessels and nutrients and the endosteum. So we already see these little holes, but blood flow and nutrients will go from, again, the periosteum into the endosteum. So that's a big advantage. After the first week, we still see some bubbles, some gas release, which goes mainly on the top of the membrane, pushing a little bit away the soft tissue, and a few bubbles underneath the membrane. That's something we need to be aware of, okay? And it's not a major or, I would say, important type of side effect, but something that we need to be aware of, because the healing is a little bit different. Now, this type of gas release is not able to push down and compress the bone particles, so we still have a beautiful blending after some months of healing. So there is no dead space underneath. Other histologies showing how these bubbles will be released. When it comes to inflammatory response, there is no signs of inflammatory response. There is a higher increase of bone compared to a traditional collagen membrane. Still, we see absolutely the results. The chemistry is quite simple. We have an oxidation phase, then followed by reduction phase, hydroxide formation, and finally also we have a breakdown of the oxide layer. And this would take, of course, a couple of months. If we use our membrane, we put in contact with saline solution, after 2 hours, we see an island of corrosions. This island of corrosion tends to get connected after 2 days. And after 1 week, we start seeing little holes within the membrane. Again, that's a major advantage because the metallic phase will be changes into and will switch into the sold phase of the magnesium membrane. When it comes to the screws, these are treated with hydrofluoric acid so that we can go through a passivation effect, which means that we're going to have even less inflammatory response, less gas release, and also the screws will last much longer. So all the biomechanical property will last for months, but we'll see the remnants of the screws for like a year after the utilization of the screw itself. So the pull-out forces are definitely much higher compared to other resorbable screws available in the market, so there is no comparison. Also, the shear load forces are much higher if we consider these NOVAMag screws compared to other resorbable products, which are associated with a lot of complications, including acidic environment and allergic reaction. So there's nothing to deal with what we've been seeing in the past. By the time we have the resorption of the screws, we see that we have newly formed bone. So there is not that space, and we have resorption from the external aspect of the screws towards the inner side of the screws. So there are no empty spaces, and we see a beautiful newly formed bone where the screws were positioned to begin with. Again, here, if we start looking at inflammatory responses, there's no inflammatory response when we use this type of screws. And by the time we switch from the metallic phase into the sold phase, we see that there is a release of phosphorus, calcium, magnesium, and fluoride, which are still utilized by osteoblasts to produce new bone. So it really looks like the holy grail here. We see 3 different sizes of the membrane. Now we have also the membrane for the NOVAMag Shield Technique, and then of course different sizes when it comes to the NOVAMag screws. Of course, we need to use a specific surgical cassette with the sculpture, the scissor, the safety cutter, the stereo wash tray, the drill rack, and of course the connector. So we cannot just use another scissor. We cannot just use other instruments. These instruments are just unique and they've been tested in such a way that there are no metallic contaminants that could interfere with the healing of the membrane. So we take our membrane, we trim it, then we bend it with the NOVAMag sculpture. We need to activate the membrane with the NOVAMag sculpture. Then we position our, of course, our biomaterials. We start fixating the membrane with these extra small screws by using the connector, which is made of PEEK. The same screws can be utilized in conjunction with the Jason membrane, of course, and then we bend it and we break the head of the screw, and we have the head of the screws with no sharp edges flashing with the membrane. And then, of course, we have to use as many screws as needed in order to stabilize the membrane. So, which are the clinical perspective? The entry level would be to use this type of technology with the NOVAMag Shield technique that we developed. So we start looking at this case. We have advanced periodontal disease. This teeth needs to be extracted, and here we see that there is the first molar is missing. There is a buccal plate completely gone, and also there is a furcation involvement. There is no good quality and quantity of the peripheral mucosa. The keratinized tissue is completely missing. So this teeth has to be removed because the long-term maintenance is not possible. So I go inside with the probe bag and see there is a deep pockets surrounding, especially the buccal aspect of the second mandibular molar, and also the mergers profile is creating an open embrasure, which is responsible for plaque and foot trap in that region. So little by little, I start disconnecting the tooth. I use these special instruments to flip the papilla and preserve the papilla, and we see that buccal plate is completely gone. So I still remove all the granulation tissues, and then I'm going to execute my extraction very, 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 very gently. We see here the open buccal furcation, about 10 millimeters of bone missing on the buccal aspect. So now, if I do the extraction, if I do nothing, the bone will collapse, and for sure, we are going to be obliged to perform a major guided bone regeneration, the lower jaw, and then wait again for 6 to 8 months for healing before placing the implant. But the best approach would be to start reconstructing the bone at the same time of tooth extraction. So here we see the buccal plate is gone, okay? And that's how we start doing our NOVAMag Shield technique at the beginning. Now we're going to see the evolution little by little together. Buccal plate is gone. I use collagen in the deepest part of the socket, then cerabone plus, and then collagen again. And then, of course, I'm going to cover the sites with my NOVAMag membrane. Okay, so I'm doing a socket preservation with a different technique, but I'm going to use this time not spondylus collagen, but I'm going to use my NOVAMag membrane in order to try to rebuild the buccal plate, which is completely gone, especially at the level of the molar. I just insert my membrane, which was previously trimmed, and I'm going to leave it exposed mainly. I know that it's going to be an open wound healing. At that time, that's how we were doing socket shields. Now we simplify the procedures. I cover it with the Jason membrane because I know that I cannot just do a full coronal advance flap in this region because I want to be still very, very gentle, and I let it heal. Okay, that's how we were doing things. That's how it was before, during the procedures, healing, and that's once we are doing the re-entry. Now we're going to do the re-entry after only 4 months. We see already that my technique allows me to improve the quality and quantity of the periimplant mucosa. I see a good keratinized tissue already without performing a free gingival graft, for example. And now pay attention to the type of bone that we're able to rebuild with this type of technique. Very gentle. I need to raise a major flap. But we can see in just a few seconds that the buccal plate is completely reconstructed. So the important advantage of this membrane is that I don't have to do a re-entry. So it is very stiff like a titanium mesh, but with lots of advantages because it's resorbable. We see all the amount of bone we're able to get. It's completely reconstructed. And now I'm going to prepare my osteotomy sites and pay attention to how hard this augmented bone can be. This is the results of the magnesium membrane because the type of quality of the bone, it is type 1 quality, I would say 100% of the time. I need to refine this bone. I need to spend time and pay attention to prepare my osteotomy sites. There is a good bleeding also due to the fact that the membrane is able to stimulate neovascularization. Let's move on a little bit further, actually. But here we see that the implant is being placed. Primary stability is really high. This can be a great advantage because we could perform immediate loading, I would say 100% of the time. And of course, we published this type of technique just last week. Moving forward, implant being placed, we did the uncovery. That's the final results. But how we change this type of technique? Well, that's quite simple. We did only the buccal plate reconstruction. So we decided to use 1 layer or 2 layers of NOVAMag just on the buccal aspect when the palatal bone is intact. And that's how we did it here. That's the re-entry, but that's very important what you're going to see right now. We place the implants, and what do we see? Something which is very common with the NOVAMag membrane. We see a buccal cortical bone when these bone particles were in contact with the inner side of the normal membrane. So we see with our own eyes how the membrane is able to influence the bone regeneration. We have a bone which is very vascularized, a buccal cortical bone in contact with the membrane, and a bone type 1 quality, I would say 100% of the time. So again, cortical bone in contact with the membrane, and then a little bit softer bone in on the inner side. Still, I would say it looks like a chin graft with type 2 bone, cortical bone on the external side, and a little more sponges on the inner side, but still great primary stability for this type of implants. Let's move on. And my friend Akiva Elad published a little bit on that. We see this type of tremendous amount of bone loss. Everything was treated with the same technology, with the same technique. The NOVAMag membrane is just positioned on the buccal aspect. And we see here that a very complex case, like all this amount of bone loss around the first back aspect, is completely reconstructed at the same time of implant placement and NOVAMag Shield technique without executing guided bone regeneration. This really can help us to treat much better our patient. This is the results. The membrane just inserted with a full thickness flap, with an envelope flap, I would say, on the buccal aspect. And then we use cerabone plus and implant being placed. And here we can see before and after. We have a complete reconstruction on the missing buccal plate. This could change completely the way you do extraction daily practice starting from tomorrow. Let me show you this very complex case. Very difficult patient. She was flying in and out all the time. Very VIP patient. And we have a very localized advanced periodontal. This is on the lower canine. She's on TV several times, so we need to speed up the healing process. Very concerned about the results. Very concerned about the surgery. And that's an amazing result I'm going to show it to you to show you how we could simplify as much as possible a very difficult bone loss. So here it is, the sites. We have an open contact due to the mobility class 3 of the canine. We have, with the periapical radiographs, a quite deep and extensive periodontal bone loss of 15 millimeters in the vertical dimension. The neighboring teeth are absolutely intact. We see the buccal plate is completely gone, and we have, of course, a mobility class 3. So my concern here is to preserve what I have on the neighboring dentition, but at the same time trying to overbuild and reconstruct the buccal plate in order to execute a few months after my guided bone regeneration. So of course here we see the probe through the density of the thin soft tissue in the buccal aspect. I spent time to remove the granulation tissue. I had to extract the tooth very gently. And then, of course, I was concerned about getting some kind of recession in the neighboring dentition because the buccal plate is completely gone. So what can we do here? If I do a traditional solid preservation, I'm not going to get the same results. I'm going to get also actually fibrous encapsulation. So I need to build up the buccal plate with a rigid metallic membrane, which is the NOVAMag membrane. So I spend a lot of time to remove the granulation tissue. Then I'm going to insert, with this new approach, the NOVAMag on the buccal aspect. Of course, I'm external to the buccal plate. I'm going down for at least 3 to 4 millimeters more apical compared to the coronal aspect of the residual buccal plate, and the membrane has to disappear. The beauty of this technique is that I'm not going to use any type of screws to fixate the membrane, because the membrane is going to be maintained by the condensation of the cerabone plus that I use here one more time, and the pressure given by the sutures. So again, I just do an envelope flap. I go beyond the residual buccal plate. I don't want to have the membrane moving into the socket. I want to be external to the socket. And then I keep pushing, condensating a lot of cerabone plus. As you see here, again, we're trying to rebuild something which is a very tricky case with 15 millimeters of vertical bone loss. And generally, I like to use collagen in the deepest part, then cerabone plus, and then again collagen on the top of it. It's an open wound healing. So I'm going to leave an open wound. I'm not going to try to stretch the tissue and try to execute a coronal advanced flap, because at the same time I can get also keratinized tissue. You see the tremendous amount of cerabone plus keep condensating in this quite large bony defect. I try to give the shape. This condensation is pushing the membrane towards the buccal. Still, the membrane has to disappear below the free mucosal margin. If it gets exposed, it will resorb faster. That's why it needs to be kept underneath the free mucosal margin. And of course, I do like a crisscross suture. To make the long story short, that's the results after 1 month. I still see some remnants of course, cerabone plus. I do see a little collapse of the soft tissue. Again, the cerabone plus is able to increase the level of osteoblastic activity. That's 6 months after we see the results. It looks like there is a good blending. And something which is very, very common when we use NOVAMag is to get house-fill units bone density above 1,500 units, which means very hard bone. That's the results after NOVAMag membrane. So now I didn't get any kind of recession in the brain dentition. The periodontium was absolutely intact on this dentition. As a periodontist, I'm concerned about preserving what I do have. But now we are ready to place our implants. By leaving the open wounds with the collagen exposed, we can get the tremendous amount of keratinized tissue, which is still so useful for the maintenance and longevity of the implant. So here it is, the results before and after. There is no loss of pink aesthetics that you see here. That's at the time of implant insertion. 100% of the implant has been inserted within cerabone plus, always leaving the buccal plate intact. We see the different periapical x-rays showing the healing before, after the graft, and after implant placement. I didn't have to manipulate the soft tissue. I did my uncovery. I didn't feel still at that time comfortable to do any medial loading and 100% augmented bone, but today that's what I would do. So now we're able to reduce the overall healing time for this type of patient. That's very, very important. So that's why in innovation, I can reduce the risk of complication, and still I can also get a better quality of augmented bone, but at the same time, I can also reduce the healing time. That's very, very important. And we see here sagittal cuts showing the amount of bone we're able to get, almost 16 millimeters in the vertical dimension. And that's the results before and after with the 3D reconstruction. You see that the buccal convexity is given by the shape that I gave myself with the NOVAMag sculpture to the NOVAMag membrane. So it tends to maintain the shape that we gave to the membrane. That's very, very important. So it looks like a block graft rather than a traditional GBR case. That's before. And we see here the sagittal cuts before and after. The results is quite amazing. And that's also 1 year post-op. We have a good results. We're able to gain again also keratinized tissue, good thickness. I didn't have to perform any kind of soft tissue manipulation before delivering the final restoration. This is the 1 year after the delivery of the final restoration. The patient during all this time was flying in and out all the time. Now let's jump into the application NOVAMag and Guided Bone Regeneration. Let's see a very simple case, straightforward case, where we have the buccal lingual collapse of the ridge after the patient lost the first mandibular right molars. We have, of course, this type of concavity. We do have enough bone to place the implant if we decide to place a very narrow implant, but that would be a big mistake because we would create a distal buccal cantilever, and the implant could fail because of overloading of the sides. So we need to follow the central fossa. We need to place our implant with a prosthetic driven insertion, and of course also we need to compensate this concavity in order to avoid foot trap. So that's very, very important. So how do we do it? Just we simplify the procedures by using always resorbable materials, and of course using the magnesium membrane. So here it is. We open up the flap. We have a full thickness flap. We see the buccal collapse of the ridge, and we need to reconstruct. I did intracortical perforation. I still use the same screws that you're going to find into the rear rack, which is the screws utilized to prepare the sides for the extra small NOVAMag screws, which is not self-tapping. Still, if it's still metal, but it's not self-tapping, so we need to create the hole to place the screws. But here in this situation, I use the same burr in order to create my intracortical perforation, allowed to get a better blood flow. We mix 50% of cerabone with 50% of autologous bone chips, and then we flip the membrane. At that time, as part of this multi-center clinical trial, we were using osteosynthesis screws, and this membrane is still compatible with a couple of different type of osteosynthesis screws, but of course it would make sense to use a completely resorbable system so that we don't have to open up the site again to remove the screws. But that's again a case done as part of this study. Coronal advanced flap, it's completely radio transparent, as you see here. We just see the membrane right on the top of the crest. 1 month after, we see a little bit more of swelling in the deepest part of the vestibule. That could be related to the release of this gas, but that's the bulkiness also that we get through this type of approach. And now we are ready to do our smart fusion. We overlap our intraoral scanning with the CBCT in order to design a guided surgical stent. We open up the sides, and what do we see here with this NOVAMag membrane? That's just always amazing every time we open again the surgical site. First of all, there is no remodeling. We get the bone exactly where we left the granules, okay? And the head of the screws is flashing with the augmented bone. So there is absolutely no remodeling. This means that we don't need to overbuild the sites. We can really rely on the amount of bone graft that we did in conjunction with the NOVAMag membrane. The second important point here is that the tissue is highly vascularized, as you can see here. So the bone looks actually a little bit different, very vascularized. The third thing that I see through this clinical picture, this is something you're going to see in your clinical practice very, very soon. But again, my advice will be to take a course because there are lots of tricks on how we can manipulate the membrane, is that there is an amazing blending. So I barely see some granules of cerabone, and we have a better blending of the site. That's very, very important. And of course, the bone is super hard. I think we could do the re-entry a few months before the 6 months, but that's how we started using the membrane as a protocol. So this is one of the first few cases that I did with the NOVAMag membrane. So I removed the screws, and we see the results before and after. Very, very easy. Now we can place the implant completely within augmented bone, following the central fossa, and of course, inserting the implant in prosthetic direction, still leaving a good thickness of buccal bone, always more than 1.4 millimeter to have that implant stable for a long period of time. And that's the final X-rays. Now, let's move a little bit further. Let's move into another case. This patient was having some kind of issue with the canine. That's, of course, a result of iatrogenic dentistry. Again, there's a stripping, there's a poor quality of endodontic treatment, there is an endoperio lesion, and there is a vertical fracture. So the canine will be extracted. So the patient was enrolled into these studies. In the meantime, he fractured also the bicuspid that needs to be removed. Now I'm ready to execute and perform my guided bone regeneration in conjunction with the membrane. So what do? I do a foot thickness flap. I release the flap as much as possible. I try to extend more horizontally in such a way that I can reduce the vertical incision that can generate some kind of discomfort for the patient. I fixate the membrane first on the palatal aspect so that I can pack my bone from buccal to palatal, and of course, still there's a mix of 50% of bone particles harvested with the bone scraper from neighboring areas and cerabone. The membrane is fixed with osteosynthesis screws because that was part of the study. Okay. Here it is. We are missing some bone, not only in the vertical dimension, because I can get bone where we have this triangle. But the buccal bone buckle is completely missing, and I need to get that convexity in terms of aesthetics for the canine region, but also to have to avoid a foot trap in the same area. So it's not only done for aesthetics and for the longevity of the implant. We see here that now we are trying to achieve also vertical augmentation for about 5 to 6 millimeters, and we see the distance between the membrane and the residual crest, as you see on the lateral view on the left-hand side of the picture. So again, here we see the beautiful blending of cerabone mixed with autologous bone chips, and we see the vertical bone which is missing right on the crest. I flip the membrane and I fix and stabilize the membrane with these screws. Now, I try to be far from the neighboring teeth for about 1 millimeter. But again, this is not an issue because that's, of course, it looks like a metal. It is a metal, but it is completely resorbable. So even if I'm touching and approaching the neighboring dentition, this is not going to be an issue. It's exactly what we do when we use the Jason membrane with the first case I showed you just at the beginning of this webinar. So here it is, we flip the membrane, as you see now here. Okay, the membrane is very, very stable. It doesn't move. I can still see the membrane right on the crest, coronal advanced flap. Of course, I reduced the depth of the vestibule in order to advance my flap. This is the results after 5 months. This is after 5 months. That's a good convexity that we got here. Good blending with the periapical radiographs. And we see, just looking at the clinical picture, before and after Guided Bone Regeneration on the horizontal direction and before and after on the vertical direction. So we're able to bring down the soft tissue because we're gaining also 5 to 6 millimeters in the vertical dimension in the same region. So here it is after. And again, what do we see here? We see that augmented bone looks like a block. So that's the beauty of this type of approach. There is no bone remodeling. There is no bone resorption. And what we see all the time, again, is hospital units very, very high, approaching 1,500 units as a value. So again, this means a augmented bone of excellent quality, and consequently, we can get a very high primary stability and execute even if we want immediate loading. But now, this is one of the first few cases done years ago. What do we see? We see something unusual on the sagittal cuts after 5 months from the Guided Bone Regeneration procedures. We see that there is a cortical bone on the buccal aspect. So this is a very, very common findings once we use NOVAMag membrane, because the bone in contact with the NOVAMag membrane tends to be highly mineralized. That's the effect of the magnesium salts. That's the effect of the membrane. So remember, we're not only using a device, we're adding nutrients. So for the first time, this is absolutely something unique, but also something that can give me an extra boost of the tissues on many, many advantages in my daily practice. So of course we do our smart fusion again. One more time, we do our CBCT, intraoral scanning, we overlap both. We see this amazing cortical bone given by the shape of the membrane. So how we trim the membrane is exactly what we can see after 5 months. Hospital units always very, very high, more cortical in contact with the membrane, and a little bit less cortical on the inner side of the sites. But again, we don't need to overbuild the sites anymore. We can definitely rely on the amount of bone that we just got. Then I do my digital wax up. I need to visualize my final results. Based on that, I can understand the depth of insertion, look at the merchant's profile, and also choose the right implant, diameter, dimensions, and look also at the exit of the screws through the final crown around the implant. So now we did our guided stents just because we were supposed to do a biopsy. We did a lot of human biopsies. That's the buccal bone balcony we can see after 6 months. We really were able to go even beyond the bone housing. We see the beautiful blending of the sites. The bone is bleeding because that's the result of the magnesium that can be a great help to have a better vascularization of the sites, which is again so important when we perform tissue regeneration. Better blending, we see just few remnants of cerabone only after 6 months. From occlusal view, we see the good augmentation of the sites, the good concavity, Again, that's the close-up of the site. We did the biopsy with the tray fine through the stent. And again, here, just look at this biopsy. What do we see? We see augmented bone in contact with the membrane, and we see native bone. And the augmented bone is more mineralized compared to the native bone. And this is the amazing results we're able to achieve with the NOVAMag membrane. So again, this is not only new, this is a real innovation. Of course, we are still learning a lot of different things. We just published a recent article last week, which is available on online. And the implant being placed, we have good buccal bone balcony, good thickness, good emergence profile. There is no need to execute any kind of soft tissue augmentation because the buccal bone balcony is going to support also the soft tissue. So that's why I postpone my soft tissue manipulation only after implant placement, not before guided bone regeneration. So we were able to achieve horizontal augmentation and vertical augmentation at the same time with a very straightforward type of approach. Different steps, as you see here, good stability of the graft, and again, lots of good bleeding once we prepare the osteotomy sites. The implant then have been placed. I just did the uncover at that time. I didn't feel like executing. I was not ready to execute immediate loading, but today I would do immediate loading, I would say, the majority of the time. I'm just doing a crystal simple incision, positioning the healing abutment, not boosting the soft tissue, but that's how it looks like after a couple of months. And then we finalize the case with screw retain full zirconia restoration. Actually, if you look at this picture, it looks almost like a typodon. It looks like a model, but that's patient soft tissue. This is very, very thick. And that's a close-up of the emergence profile that we see through the sites. Good convexity of the pink aesthetics, which is following the convexity of the white aesthetics. So this patient won't have any kind of foot trap, and this will be maintained for a long period of time. So I published also this case in this beautiful book published by Quintessence, and I published a chapter just on magnesium technology. So when it comes to the conclusion, the NOVAMag membrane is a metal. The magnesium is a metal, but it's the 11th most abundant ions in our body. It is very strong, it is stiff, but it's still degradable. It degrades into the magnesium ions, and these ions will be utilized by stem cells and osteoblast cells to produce bone. So this is an ideal regenerative materials because this is not, again, just a device. So I got highly mineralized regenerative bone, very vascularized, bone type 1 all the time, cortical bone in contact with the NOVAMag membrane. And there is, I would say, potential for reduction of overall healing time, which has been always an issue in guided bone regeneration, dealing with long period of treatment for these patients. Now, the same case, after some years, I had to do some kind of bone augmentation on the lower jaw. So you see here, there's an edentulous area in the first left mandibular molars. So that's, of course, an excuse to look at the site 3 years after the delivery or the final restoration. So this is the case with the longest follow-up after the use of NOVAMag membrane. And we see the same results. There is no remodeling. We still have, after 3 years from the delivery, the final restoration, we're talking about 4 years from guided bone regeneration. We still see the volume, which is very, very well maintained. So we went from this, that's a pre-op pictures, to this, and actually this is the results after 3 years from the delivery again of the final restoration. We, of course, could take other views of the site with the sagittal cuts. We still see that the cortical bone, the buccal aspect, is very well maintained, and there is no resorption. And if we look at the thickness, exactly what we wanted as dimension of the buccal bone balcony, that's 3 years after. So this is very, very well maintained. So with this, it was a quick overview on the use of magnesium technology. I'll show you how we started and also the little journey we did together, starting from the JSON membrane, then use the mucoderm, and then switch into the use of NOVAMag Shield Technique to build up the buccal plate. And then finally, we jump into Guided Bone Regeneration for horizontal and a combination of 3D body defect with the use of magnesium membrane. So thank you very much. And I think now we have some time for questions, and be more than happy to answer to all your questions. Thank you very much.
Thank you, Dr. Giorgio Tabanella, for this extremely interesting presentation where you exposed all the pros and cons of the use of this membrane and the advantages of using the magnesium NOVAMag membrane. Would you please unshare your screen so we can talk about this presentation? And I start with the first question, that is, we know that the membrane is enough to create a space under the periosteum to have bone regeneration. So what is the role of this membrane? Is it because it's a hard membrane that will keep up the space that has been created under the periosteum to have a bone regeneration?
Okay, the most important part when we do Guided Bone Regeneration is the tenting effect of the membrane. So since we are dealing with a metallic membrane, but still resorbable, so it's not like a titanium mesh, we can better obtain a tenting effect and better prevent the collapse of the membrane. So in terms of mechanics, it is much, much better, and there are many, many advantages in that sense. But then also the fact that it's releasing some kind of nutrients also make the membrane just unique, and the fact that we still see some holes after 1 week, and we get nutrients going from the periosteum into the endosteum, but still maintaining a tenting effect is of great help, because we see a better healing of the bone. The bone quality is just amazing when we do the re-entry. It's completely different compared to other type of technique, titanium mesh, titanium reinforced membrane, or even collagen membrane.
What are the potential complications, if any, of one example, encapsulation of this membrane or perforation of the soft tissue that is covering the membrane? What are the risks? Is there any cytotoxicity of this membrane?
Okay, the magnesium, that's super interesting question, super smart question. Thanks for asking. The magnesium is part of the body. Okay, we take the magnesium from the diets, so it's not toxic, and it's not, I mean, in order to be toxic, we should intake a large quantity of magnesium, so there is no risk whatsoever, even on patient with kidney dysfunction in that sense. Okay, because the magnesium which is released in the body, magnesium is very limited. Then when it comes to complication, of course, again, this is very tricky. So as I was saying before, even I've seen super expert in Guided Bone Regeneration having issue with the membrane. So it's important to go through a learning curve and to do it properly since the beginning, even if you're super expert, okay? Because I've seen really people not attending courses specific on NOVAMag and having lots of issues. So the membrane is absolutely safe. Since it's resorbable, if it gets exposed, it will resorb. So nothing major is going to happen. Actually, it will resorb faster. Of course, we would like to have the membrane completely covered by the tissue because we will have a better tenting effect. But in case it gets exposed, nothing bad is going to happen. Actually, I just published a few days ago an amazing paper, which is the results of my research, which is you can find online. It's open access journal, where we show a completely different type of healing, even in case of complication open wound healing, patient would completely heal uneventfully, and we won't lose any kind of bone reconstructed, and no pain for the patient, no suppuration, no infection. So actually, I see great potential, great results, less complication definitely than a titanium reinforced membrane or non-resorbable device.
Any risk of encapsulation of this membrane?
No, there is no risk of encapsulation.
Okay. And what about if you have an exposure during suturing? I mean that if you did not release enough the soft tissue, what would be your attitude? Would you put a resorbable membrane underneath it or on top of the?
Yeah, if I want to have that wound very, very stable and try to get as much as I want to get from that side, I would cover with the Jason membrane, let it just on the top of the NOVAMag, and then suture it on the top of it. But still, I mean, we're really safe because it's resorbable. So we won't have any kind of major side effect.
What about if there is a anticipated a quick resorption of this membrane? What would you still get the result that you have hoped for?
Actually, the membrane start the resorption after 1 week, okay? But it switched from the metallic phase into the salt phase, which means that we're gonna have layers of salts, magnesium salts, and this will act together with the gas release also as a tenting effect. So the membrane really starts resorbing after 1 week, but it's gonna take 2 months before it's gone, and it's gonna take 16 weeks before there's no remnants of magnesium within the cells. So it's important to understand the mechanism behind this type of technology, because again, in other case, if we already get the resorption after 1 week, it would be a complete failures. But here actually is a major advantage because you get nutrients from the periosteum to the endosteum, and also the magnesium salts will still have a tenting effect together with the gas release.
Mm-hmm. Can you use it around the teeth to restore bone in cases of periodontitis? As a periodontist, have you ever tried it to build up a crater around a root or a tooth?
Yes, of course, you can do everything. It can be utilized like in all the indication where you use the collagen membrane, and it can do even a little bit more the collagen membrane, definitely. Yes, of course, I use it also for periodontal defect.
If it is in contact with the tooth, will it induce a tooth reaction, kind of a resorption or ankylosis?
No, the only thing is if it get exposed, it will resorb faster. If it get exposed and the patient is drinking Coke, it will resorb faster. If it get exposed and the patient is eating something which is very acid, it will resorb faster. If the patient is using hydrogen peroxide to do some rinsing, it will resorb faster. So the more is underneath the soft tissue, the better it is. In case it get exposed, it's gonna heal. It's gonna heal, okay? But of course, it will resolve a little bit faster. And in that case, we need to avoid, of course, the contact with acidic food and hydrogen peroxide.
Mm-hmm. What about peri-implantitis? How effective is it in the cases of peri-implantitis in submerging the implant, covering it with the membrane and all this? Would it be a help for that?
Definitely. Again, I don't see different type of application compared to other collagen membrane. So of course it can be utilized. Actually, the tenting effect is much better in that sense. And again, we add the nutrients to the site. So it's still an ongoing learning process because the results are quite impressive, and we saw a lot of different applications, really.
And could it be done also in cases of immediate implant placement after extraction?
Yes, of course.
Mm-hmm.
Absolutely.
Yeah. Have you extended this application to a full edentulous maxilla or mandible in reconstructing the edentulous mandible or edentulous maxilla? Or
Myself,
is it always sectional?
okay, I had to, as part of this multi-center trial, I had to focus on partial edentulous patients. So we did all these cases on partial edentulous patients. Of course, it can be applied for a full maxilla or full mandible. There is no contraindication. Of course, it would be a little bit tricky, the provisional phase for this patient. Certainly, we cannot provide like a denture on this type of cases. But again, there is no contraindication in that sense.
Mm-hmm. Here is a question for if we have an anterior bone loss, do we have to place a membrane buccally always? Actually, definitely you have to restore the resorbed or the defect. So most of the time it's the anterior defect.
Yes.
Okay. Do you always mix the cerabone or allograft with allograft with the vital bone?
We don't use allograft in Italy. We are not allowed to use allograft. I mixed all the time cerabone or cerabone plus with autologous bone chips.
Autologous. Do you always mix it with autologous bone? And if you're mixing it, do you have to open for another site or is it taken from the same site?
Okay, if I do Guided Bone Regeneration, I always mix it with autologous bone chips. I always harvest from neighboring areas. So it's very rare unless I need a big quantity of autologous bone that I raise another flap. Okay, always trying to collect from neighboring areas. If I do socket preservation, I just use 100% of cerabone plus or cerabone. I don't mix it with the bone because it's a self-containing defect, so there are good potential for tissue regeneration. There is no need to harvest autologous bone chips.
Look, in my experience, I'm a prosthodontist, but I always suffer from these, I call them errant bone chips from cerabone or different kind of bone that is used in bone graft, not autologous bone, but all these bone substitutes that we use, they have most of the time errant particles that cause inflammation sometimes. What is the situation in this kind of restoration that you're doing with this membrane? Do you see these kind of rogue particles coming out in the sulcus after the implant placement and the prosthesis?
Much less compared to collagen membrane, because the blending is definitely much better with NOVAMag. And we see, even just looking at the picture I showed you before, we see a few remnants of cerabone. So there's sort of acceleration of the healing process of the bone. There's really something you can see in the daily practice. You see it yourself. It's really visible, and I'm looking forward to seeing and to showing to you in the near future, maybe next year in Dubai, human histologists. We're still waiting for human histologists because the clinical results are impressive.
Have you done a comparison study between using bone substitute with autologous bone and not using anything, just creating an empty space under this membrane?
No, because I mean it works very well into the sinus, okay, in order to create that space. But in clinical situation where we have to perform guided bone regeneration in the lower upper jaw, there isn't. I mean, we need bone particles. We need bone particles. It would take a long time. We won't get the amount of bone that we can get with this approach. So we always
have you tried only autologous bone instead of bone substitute mixed with autologous
No,
bone?
actually, that's a very interesting question. Actually, we have seen that the best results is given by a combination of bovine bone and or allograft and autologous bone. Actually, cerabone and autologous bone chips, or cerabone and max graft, which is an allograft. Okay, so it works very, very well, but there's always a need to use some kind of bovine bone because it will resorb we will see like a delay in the resorption, and we will keep a better blending of the sites. So I wouldn't use 100% autologous bone chips because the performance, final performance, is much higher by a combination of both.
Many questions that are not related to the topic of this presentation. I'm going to go past these questions. So we still have to have many other studies, ongoing studies on this kind of membrane that is a promising membrane. How long has this membrane been on the actual open market?
I think I did the first presentation years ago, maybe 3-4 years ago in Tel Aviv. It was the first presentation worldwide. In Europe, we have it available. I mean, I think I don't remember exactly, but 3-4 years, and now it's available in Japan. It's available. It's going to be available soon in Canada, in North America. So it is a membrane which is going to be available everywhere in every single country very soon.
So it's still a membrane that is emerging on the market, and it's a promising membrane on this market.
I don't think it's a promising membrane. I think it's a real it's a real thing. It's not promising because, yes, because we have seen amazing results. Now we've been using the membrane for like 6-7 years, and the results are quite impressive and very long lasting. So it's not promising. It's something real, absolutely something real that can allow everybody to do guided bone regeneration, but still reducing the risk of complication, which is very common in guided bone regeneration.
Yeah, definitely need to have a good release of the flap, and it has to be without any sharp edges to perforate the membrane, the covering soft tissue, and it should be properly manipulated without any contamination of this membrane.
Of course.
Dr. Giorgio, do you have any final words before I close the session?
I mean, we're super excited because we have seen and learned ourselves things that we were not aware of during all these years of advanced research. Wherever I go, could be Japan, it could be Canada, it could be South Africa, wherever I go, really people get super excited, but it's the reality, okay? That's something you're gonna judge yourself in the daily practice. You don't have to trust me. You just go and you'll see the amazing results, and you'll see how this could improve the quality of your practice, the quality of your dentistry. Again, my suggestion would be to start with the NOVAMag Shield technique because that's the easiest approach. And it is really, really important to go through a learning curve and to do some, you know, type of courses in order to reduce the risk of complication, because the handling, it's a little bit tricky, but it's we're going to have a lot of fun in the near future, for sure.
A question that popped up to my mind, do you get custom-made membranes on this, or is it only regular stock membrane?
Not yet. It would be amazing, but trust me, it took many years before botiss was able to produce something like that. The production process is very complicated, very complicated. So right now, no, it's not possible. I think in the near future, maybe it's going to be possible.
Yeah, it would be interesting if we have a custom-made membrane, CAD/CAM made membrane of this type, and it will be much easier to manipulate in the mouth of the patient without any sharp edges or any kind of difficulties in placing it. Absolutely. With that, thank you, Dr. Giorgio Tabanella, for this very interesting presentation. And thank you for our participant for being with us. Thank you for our supporter, botiss, and definitely thank you for CAP for giving us the opportunity to air these free webinars. Within the coming 24 hours, yes, you will be receiving an email with two things. One link to the presentation that you will be able to review, and a certificate that you can be able to download for your interest. And with that, I would like to thank the CAP team for giving us the opportunity and helping us with the technical support. I wish you a good continuation of the day.
Thank you very much. Thank you for hosting me. See you soon.
It's a pleasure.
Bye. Bye-bye.
Bye.